So it's a 71 years old woman, and she had infrequent sinus pauses during night, pauses of 6 seconds. So it's a perfect indication of nanostim implantation because she had only infrequent 6-second pauses during night. She had only history of transient ischemic attack, but she had no symptoms of bradycardia. So first, we use a 9 French introducer in the right femoral vein.
We prepare the femoral access.
Yes, but the femoral access is not easy in this patient. So we perform a venous puncture with a 9 French introducer and with a long needle because this patient is relatively obese. And we check under fluoroscopy. Okay, it's okay. We do little incision because it's a large introducer, 1 centimeter. Okay. And we introduce the 9 French. And after, we will use the technique of the candle. In fact, we pre-dilate the vein with a lot of introducer. We use a guide wire. First a soft guide wire, but sometimes we use a stiff guide wire. You can see the progression of the guide wire. The direction of the vein is not perfectly direct, straightforward. And we will do some exchange with the 14, the 10, the 12, the 14, and the 16 French introducer to predilate the vein. We predilate with the 12. It's not very easy. We'll check the fluo. No. I think we need a stiff guide wire. So we will introduce a long sheet. Valerie, yes, I will try a long sheet, a long introducer, 23 centimeter. You can see on the fluo that the vein is very tortuous, with a lot of curve, and we need a stiff guide wire. So we'll do an exchange. Yes, very, very curvy. So we use a 23 centimeter introducer. We will exchange, we'll do an exchange with a very stiff guide wire to rectify the curve of the femoral vein. We need to advance very carefully along the vein with this guide wire. Because this stiff guide wire may be dangerous. So now you can see that it's direct, and we will do an exchange with 12 French, first the 10 and then the 12 French. You can see that it's very easy now with the stiff guide wire. Okay. So it's a pre-dilatation technique. It's very easy now with this stiff guide wire. It's an on-plate super stiff. Okay. And now we take the introducer of the nanostim pacemaker. This introducer is here. You can see the introducer as a dilator. It's an 18 French introducer. We'll flow the introducer. Okay. And then we introduce the 18 French nanostim introducer. And it's very easy. You can check on the fluo, but it's straightforward. You can see that the introducer is now in the inferior vena cava. So we remove the dilator.
We flush the introducer.
So we flush the introducer, we put a low pressure flow. In the lateral arm of the introducer. So now we are ready to perform the right ventricular angiography with a guide wire. So, but here I need a soft guide wire for the ventriculography. So you can see that sometimes it's not very easy to put the introducer, the 18 French introducer, but you can see also that we don't need to perform an angiography, because with a stiff guide wire it's very direct, and we can advance over the wire the introducer without opacification of the vein. There were several steps. The first step was with a non-traumatic guide wire, a Terumo. Then we use a long sheet, long introducer, 23 centimeter, and after a stiff guide wire. And finally, we pre-dilate the vein with a lot of guide wire from 10 French to 14, 16, and finally 18 French. So now we advance we advance the pigtail in the right cavity. Okay. So we try to use the guide wire to go close to the apex. Yes. We think that it's not so bad. We are in the right ventricle. And we will connect the pigtail with the three-way. We use a three-way stopcock.
Attends, ouais, c'est bon. Continue. Ouais.
Okay. And we use
Inspire.
an automatic injector, a Medrad. So there is no bubble, so I think it's perfect. Okay.
On va armer. Ah oui, test.
We will do
We have gone through
a test in 30-degree aerial view. Okay. First, small test. Valérie. Okay, it's perfect. And then we perform the definitive right angiography. Ready? Yes? Okay. So very good angiography. We can see the right ventricle in aerial view. And we can check where we will insert the nanostim pacemaker on the apicoseptal part of the right ventricle. This right ventricle is not dilated with a very good ejection fraction. And we put on the right side on our screen a reference to be sure during the implantation of the nanostim that we are close to the walls of the septoapical right ventricle. As you can see, we do the implantation in our cath lab with high quality fluoroscopy. I think it's very important to perform implantation of nanostim in an operating room like this operating room. I'm sure that the quality of the fluoroscopy is very important. My advice is to don't use mobile C-arm because the quality of the fluoroscopy is not enough to see all the components of the nanostim, and particularly the marker. The marker of the nanostim is very important to see because we have to screw the nanostim and to look to the marker to be sure that the nanostim is well screwed in the right ventricle. We need a very long table because the nanostim is very long with the delivery catheter and the nanostim. So we need to put the nanostim on the table. And we take all the delivery catheter and the nanostim. We let in place the protecting part here of the nanostim because you can see that the fixation is a screw, and we have to protect the screw to avoid to damage the screw.
C'est high pressure?
Yes.
Because if the screw is not perfect, we have to replace the nanostim. Then we will connect all the flow to the nanostim delivery catheter into the introducer.
First, a low pressure line on the LP
So we
introducer.
put a low pressure on the LP introducer. Okay. We put a high pressure line. Yes.
Ah oui,
We need
here.
a three-way cock between the protective sleeve and the high pressure.
This is on the delivery sheet.
The other. Okay. This one.
And the last one is on the handle.
The three-way introducer, the three-way cock, it's for the syringes, for the injection of dye. Because we need to inject dye to be sure that we are close to the wall and not too close. And the last one is on the handle. It's a high pressure flow. So there is no bubble. It's quite perfect. We will now remove the protection of the leadless. The leadless is presented undocked. And we will show you the nanostim pacemaker with the tether. So it's in tether mode. We can see there the screw. It's a very original fixation mechanism with this very small screw. And you can see there the protective sleeve to advance the nanostim on the infravena cava and the right ventricle, the right atrium and the right ventricle. We'll do now some tests. We will dock the nanostim. I will explain you the handle. There is 3 knobs on the handle. First knob is a deflection knob. The second knob is a LP control knob, and the third knob is a release knob. So it's very easy, and there is a lateral arm on the handle. It's very important to see if the deflection of the nanostim pacemaker, of the leadless pacemaker, is on the same angle or not of the lateral arm. And we will check what is the difference in angle between the arm and the deflection of the introducer. I will show you how we dock the nanostim. Look. Then we will try to exercise the protective sleeve on the nanostim introducer. Like that. 1 time, 2 times, 3 times. Okay. It seems perfect. And we will exert the deflection of the delivery catheter and try to see what is the angle between the deflection and the lateral arm. Okay, so I think it's relatively opposite to the arms, to the lateral arm. 1 time, 2 times, 3 times. It seems perfect. Then we will remove the protective sleeve to introduce the nanostim with the nanostim introducer. So then we protect the nanostim and the screw with the nanostim introducer. We will remove the pigtail because we don't need the pigtail now. So we will introduce the introducer of the nanostim inside the 18 French introducer. It's okay. And we advance the nanostim inside the 18 French introducer. We check under fluoroscopy that we advance very slowly, very carefully. You can see the advancement of the nanostim. Now the nanostim is inside but unprotected. Don't take care because it's unprotected. So we stay just inside the inferior vena cava, just after the exit of the introducer, and we will check by the telemetry the right functioning of the pacemaker. We remove the nanostim introducer because we don't need now the nanostim introducer.
So we check the telemetry. Telemetry is okay, so we can interrogate. It's going out of the shelf mode. Communication is okay, so we can go on with the implantation.
Okay, we go on. So now we need to advance the nanostim along the inferior vena cava and the right atrium, but we need to protect the nanostim with a protective sleeve. So now the nanostim is outside of the 18 French. We will protect with a protective sleeve. We have a little marker, so now it's protected. And we will advance the nanostim to the right atrium. Just 1 minute, Peggy, because sometimes there is a valve between the inferior vena cava, not easy to pass. Okay, I think it's okay. Yes, we are inside the right atrium. We will do the advancements of the nanostim inside the right heart in aerial view. We use the lateral arm to know the orientation of the nanostim because we have seen that it's opposite to the arm of the handle. So we'll try to go inside the right ventricle. Sometimes not so easy.
It's important to begin to angulate the sheath at the insertion of the right atrium and the inferior vena cava.
Okay, so now we are inside the right ventricle, not too close to the wall. Now we will check the position of the nanostim, and the nanostim is protected by the protective sleeve. We will do an injection manual injection of dye. It's why we need this three-way cock. And we will do an injection inside the right ventricle. So the best position is an apicoceptal position, and we will check in aerial and also aerial view to be sure. We'll do a little injection. Yes. I think it's a good position because we are relatively septal. We'll check in aerial view. And in aerial, we are septal. It's clear that we are septal. We go back in aerial. And the next step is to remove the protective sleeve inside the right atrium. Very slowly, very carefully.
How do you make sure that your device will not move?
The device is relatively stable, and we don't need to lock the curve, in fact. I think it's stable. We will see.
You don't have to push. You
don't-
have to stay
Yes.
straight.
So we remove the protective sleeve. The position seems very good. My advice is to not push the nanostim on the wall. I think we can see the movement of the right ventricle, and the curve seems very good, very harmonious. The next step will be to check the measurement before screw, to check the detection, to check the impedance and the threshold.
So I will start with the impedance.
So we measure the impedance
1000.
1000.
I will check the
What is
sensing.
acceptable, Cedric? Between 200 and 2000. So 1000 is okay.
Indeed. The sensing is 9 millivolts.
9 millivolts of sensing, very good.
So I will do the capture test.
We accept up to 3.
Yeah. I will do the capture test. The patient is very fast.
Yes,
so
because patient, the rhythm is very fast. It's a natural tachycardia.
which rhythm do you want?
I think we will try
140.
140, yes, to be sure, to have a capture.
So 2.5
Yes.
volt, 140. So
Capture at 2.5 is okay.
Yeah, 225,
225
Two.
okay. 2 okay.
175, 15, 125.
Yes. So the threshold unscrew is around 125. So I think we can now screw the leadless, because we are quite sure that the position is a very good position.
We have taken the picture in reference to
Yes.
have the mark to do the rotation.
Yes, you can see the marker on the right screen. It's a reference screen, and we will do one turn between 1 and 1.25. So we will turn the handle to screw the nanostim, not too much at 20 click, generally around between 10 and 15 click.
And it have to be very slowly
Yes,
and under fluoroscopy.
under fluoroscopy. So we have a reference screen with a marker, and we have to do at least one turn. I will begin.
Usually you have to do 4 or 5 clicks before you see that the device is moving.
1/4. I will wait, because the transmission is sometimes very slowly. Very slow. The transmission is sometimes very slow. So we have performed half a turn.
Almost, yes.
One turn, maybe a little more than one. No?
I think it's a little more than 1.
1.25.
It's enough. You can see that we have to perform the turn very, very slow, because sometimes there is some inertia, and the transmission can be made very quick, very abrupt, very acute. So it's very important to do the turn and the click very slowly, because we have to do only one turn between 1 and 1.25, never more than 1.25. It's very important. Okay. So I think now the device is screwed. We do an image. And then we will do the threshold in passive mode, in tether mode. We'll do the threshold in tether mode, and to be in tether mode, we will undock the handle with these two buttons. Okay. So now we are in tether mode, and we will do a deflection test with my handle and with a fluoroscopy, and better in graphy. You can see, okay. It's important to do a 30-degree deflection to be sure that the nanostim is well screwed inside the right ventricle.
If you had difficulties to look at this deflection test, what would be your advice?
If I had difficulty, I try to do the deflection test in ALO mode, and I will do. You can see the LAO. I will do a graphy. It's not very informative, but I think the first was very good. It's very important to look to the fluo and to be sure that we have a movement of the proximal part, but we have no movement of the distal part of the nanostim. It's very important to be sure that it's well screwed.
So I will perform the test. So impedance was 1000, is now 380. So this is an evolution. Sensing is now 7.5 millivolts. It was 9.
So sensing 7.5, impedance
390.
319 instead of
1000.
Yes.
And I will perform the...
So the conditions change.
Yes.
So you can show that
The threshold
we have
test.
screwed the nanostim.
6 volt, 1.5 millisecond is maximum output for phrenic stimulation.
So we check for the phrenic capture. No phrenic capture, so it's okay.
So down to 2.5 volts, 0.4 milliseconds.
2.5, loss of capture.
We had the loss of capture, but now it's capturing.
Okay. So 2.5, Cedric, now?
225, so we
Okay.
got a loss of capture.
So for the moment, we are in the acute phase. The threshold is 2.5 volt, but we are relatively sure that we are screwed because the impedance decreases and the sensing decreases relatively, but from 9 to 7.5. So, and the threshold are 2.5. We will wait, and I think it's very important to have only one position and to not reposition the nanostim. If we wait, sometimes we wait half an hour, we will do some tests at 5 minutes, 10 minutes, 15 minutes, and if there is a decrease of the threshold, we are sure that the leadless is well screwed. And we are relatively sure that tomorrow or in half an hour, the threshold will be excellent, less than 0.5 volt. So we will wait 5 minutes to be sure that the threshold are decreasing. So we have a great experience with nanostim. We have implanted 35 nanostim pacemaker since 2013, 2 years ago, and all our thresholds are below 0.5 at 24 hours. So the threshold with this screw are excellent, always excellent. So if there is a trend with a decrease of the threshold, we are extremely confident for the good position of the nanostim, and we are quite sure that we can release the nanostim in this position. I think it's very important to try to not have several positions of the nanostim, because if we try to have several positions, we multiply the risk of complications. So we try to have only one position. And I think this position is a good position.
You can see that it's not a painful intervention. Here the patient is have a sedation, but we have done some intervention with just a local anesthesia, and there is never problems.
Yes,
with
it's
it.
enough. And it's a very cosmetic intervention for this patient without any scar, without any risk of local complication, no hematoma, no risk of local infection. Okay.
What would be your advice for a good threshold in order to release your device?
I think it's very important to have a trend. If there is a trend with a decrease of the threshold, if we begin at 3 and there is a decrease and we have at 5 minutes 2 volts, I think we are relatively sure that it's a good position and that we can release the device.
So would you advise 2 volts or maybe 1.5 volts as a cutoff?
1.5 is better, but if we have 2 volts and there is a trend to a decrease and the position is okay, I think we can release the device. We have done a release sometime at 2 volts and always an excellent threshold at 24 hours.
Right. The idea is if your first threshold is even 5, it can be okay to wait a little and to see what is the evolution in the first minute, not to go on through a repositioning immediately.
Yes. I think that we know that it's a large screw. Small screw, but large. The screw of the nanostim is large, but it's not deep, only 1.3 millimeter deep. But the current injury induced by the screw of the nanostim is very important. And for the moment, with this third generation, we cannot record the current injury. So we have to do with not direct measurement, with the impedance, with the threshold, and with the sensing. We hope and we are sure that with the second generation, we will see the current injury to be sure that the screw is perfect. So we are at 5 minutes, and we will do the threshold at 5 minutes. I think we can do the threshold at 100 and 120. I think it's
Impedance is 460 ohms, a bit more than before, which was 390.
So the trends.
The sensing is 7 millivolts, so stable. It was 7.5.
Impedance increases a little.
And I start the threshold at 3 volts, 140 bits per minute, 275, 2.5.
You have a lot of fusion now, but it's okay.
225. Do you want me to increase the rate up to 150?
No, it's okay.
2 volts, 175, 1.5, 125, 0.75.
Okay,
Loss.
it's there.
1 volt.
So the threshold at 5 minutes is now 1 volt. So there is a trend, very acute trend, to decrease the threshold. The threshold just after screwing the nanostim was at 2.5, and at 5 minutes the threshold is 1 volt. So now we are sure that the position is good and the nanostim is well screwed. So I think we have performed the deflection test. We can release now the nanostim. So we use the release knob clockwise. We pull back the knob and we will turn clockwise the knob 5 times, and after we'll use a jiggle technique to definitively release the nanostim. So we'll do under fluo 1, 2, 3, 4, 5, and jiggle technique. Okay. Okay. I think the position is excellent. We removed the delivery catheter. Okay, seems perfect. We will check in LAO view. Excuse me, for the anesthesiologist. And the position seems perfect in LAO view. It's a septoapical position. We will remove the catheter. And the last part will be to do a suture, a 8-stick suture. We don't do any compression. We do only a suture, and it's enough. And we will remove the suture, cut the suture the day after. So we can see that there is no blood, no scar. It's a very cosmetic operation for the patient. So we'll remove from the introducer the delivery catheter. You can see the delivery catheter with the tether, and then we remove the introducer. And we'll do one suture, and it's finished without any blood and without any compression. So now the operation is finished, and we will do the measurement, the final measurement.
Impedance is 410.
Impedance 410, okay.
Sensing is 11.5.
Sensing 11.5, it's excellent.
Capture 1.
And capture.
I start at 1 volt, 100 bits per minute. 1.5. Je vais aller plus vite, je vais aller à 120. Ah. 1.5. 1.5. Intermittent à 1.25.
Sensing 1 volt, so it's okay. It's
Threshold.
perfect. Threshold 1 volt. Okay, it's perfect. It was a very easy intervention without any problem, under only sedation and local anesthesia. The fluoroscopy time is only 5 minutes. The operation is now finished without any scar, with only one suture. So you can see that it's very easy to perform.
The final programmation would be VVI 50, 2.5 volts output, sensitivity 2 millivolts.
This patient was implanted with only paroxysmal pauses. Probably the rate of pacing will be very infrequent. What will be, Cedric, the longevity of the pacemaker if we consider that the percentage of pacing will be around 10% of the time?
I guess it would be more than 20 years. Our estimation for a VVI pacemaker, 60 beats per minute, 2.5 volts output, would be almost 18 years for 25% stimulation.
18 years, it's excellent.
Yeah.
So the question is what to do at the end of life of the pacemaker. We have two solutions. First solution is to put another leadless pacemaker just beside the other. The second solution is to retrieve the pacemaker, and we have a tool to retrieve the pacemaker. It's the same handle. You can see it's a demonstration catheter. It's a shorty catheter, but you can see that there is a lasso catheter with the same handle, and we can retrieve the catheter. We have performed a retrieval one time 14 months after implantation without any problem and without any encapsulation. And we have some hope that several years after implantation, we will retrieve the pacemaker. We need to confirm that there is not a lot of encapsulation after several years to be sure that we can retrieve the pacemaker. But I think there is a hook. You have seen that there is a hook at the proximal part of the nanostim, and the hook is designed to retrieve the nanostim, and we can recapture the nanostim with a lasso, reinsert on the delivery catheter, and unscrew the leadless, and retrieve the leadless and place another catheter. But there is some question concerning the degree of encapsulation several years after implantation at the time of replacement, of course.